Well, good morning, everyone. It's such a pleasure to be here. Thank you for that kind introduction, Lisa. I always look forward to this event, and so great that you're taking the time out of your weekend to be with us today, and just an absolute delight to engage with you. We've set up a session today, Dr. Halloun and I, that's going to be interactive, and so we're really hoping that you'll warm up as the morning goes on and engage with us in this important space. These are my disclosures. I do partner with industry to bring novel muscle and bone therapies to children with rare diseases, and the funding for that goes to my institution, and Dr. Halloun has no disclosures to declare. So this is all about dealing with the endocrine and the bone health issues in Duchenne muscular dystrophy, and what you need to understand is that steroids help muscle in Duchenne. Steroids prolong ambulation, they provide cardiorespiratory protection, they improve upper limb strength, but they do have side effects. And so as endocrinologists, Dr. Halloun and I and others across Canada are dedicated to working with families and neuromuscular experts to minimize the side effects of steroids so that the individual can maximally benefit from their steroid therapy. So that's the topic for today. This is an area that's so important that we've started an international working group called the Optimized DMD Consortium, which is comprised of healthcare professionals and patient advocates from across Canada and the US and the UK and Europe in order to deal with this issue on local, national, and global stages. I'll be presenting today with Dr. Rana Halloun. She's already been introduced, but I just want to mention that she's been with me since March. In a very short period of time, she has impressed me with her tremendous desire to learn and the positive energy that she brings to the clinic. And she's made tremendous strides in her research portfolio working with my group as well. So it's just a pleasure to have her here today presenting with us. And she's funded for her fellowship by Parent Project Muscular Dystrophy, as well as Defeat Duchenne Canada. So we've set up this hour so that it's maximally interactive. Dr. Halloun will be reviewing each of the bone and endocrine topics for about 5 to 8 minutes, and then we're going to open it up to the floor. We want to hear from families, we want to hear from individuals living with Duchenne, we want to hear from caregivers and siblings and grandparents of caregivers, we want to hear from health professionals. So we do indeed hope that this will be interactive. And we're going to be covering bone health and bone protection, growth, puberty, weight management, and adrenal suppression. So as many of you are likely aware, the dystrophinopathy, the Duchenne itself, causes osteoporosis, which is bone fragility, because muscles are important for bone strength. And individuals with Duchenne are also a little bit shorter than their healthy peers, even in the absence of steroids. And then steroids, also called glucocorticoids or corticosteroids, exacerbate the bone fragility potentially. They cause short stature that is amplified, and delayed puberty, adrenal insufficiency, and weight management issues. So that's what we're talking about today. One of the questions we get asked is, when should a boy with Duchenne be referred to an endocrinologist? And the answer to that is really as early as possible, although different clinics have different capacity to receive patients at different time points in their journey. So that's something to keep in mind, but we do think that a referral to an endocrinologist should occur earlier rather than later, and no later than steroid initiation, if possible. So with that, I'm going to turn it over to Dr. Halloun to introduce the first topic, bone health and osteoporosis, and then we'll follow up with some questions. So have your questions ready to go.
Thank you, Dr. Ward. So when we are talking about bone health and osteoporosis, what do we mean by osteoporosis? Well, osteoporosis happens when bones loosen their strength, their density. And with this, they become weaker and are prone for bone fragility fractures. As you can see, in a normal bone, we want bone to have a certain amount of density and elasticity with some pores in it, not too dense like a chalk or too soft like a sponge. Healthy bone looks like a honeycomb. with tightly packed interconnected trabeculae. While in osteoporosis, bones become weaker, less dense, the trabecular are thinner, not well connected, and we have less trabecular. And that is the reason for osteoporosis. In boys with Duchenne, muscle weakness and steroids use are the main drivers for bone fragility fractures, with the muscle weakness as a key driver for the long bone fractures, long bones such as the tibia, the femur, and with steroids exacerbating this risk for long bone fractures, while the steroids are the main driver for the vertebral fractures, with muscle weakness increasing this risk for vertebral fractures. So how do we monitor and evaluate a boy with Duchenne for his bone health? First, we take history. We ask about previous fractures, about back pain, bone pain, and about mobility. And our tools include bone density exam and spine X-ray that I will elaborate about now. Spine X-rays are the most important modality for monitoring bone health, as vertebral fractures are the earliest signs of osteoporosis. These fractures that can be painless are usually manifested as a small decrease in the height of the vertebral body. And if left untreated, these can collapse and can increase the risk for more vertebral fractures in the spine. And as a result, there can be deformity and loss of height of the spine. And in fact, vertebral fractures are the early sign of osteoporosis. And this can happen after a few months of starting steroids or an average after 2 years. As for the long bones that we have discussed that can be affected by the muscle weakness, you can see a picture of the femur in a boy with DMD at the age of 13 years. You can see that the bone is more pale, is thinner, as opposed to a healthy bone. And you can see the arrow pointing at a little crack. That is a fracture, a fragility fracture. Additional to the spine X-ray and the fractures, we do monitor the bone density. Bone density is our other modality for monitoring bone health. When bones get weaker, more pale, as we saw in the earlier X-ray, the bone density drops. The decline in bone density happens before we see a fracture. This is our way to understanding the potential of developing bone fragility. This is on the pathway to osteoporosis. A single assessment of the bone density is not very informative. We do follow the trajectory of the bone density through the years. And as you can see, we monitor the bone density in multiple sites because multiple sites are affected differently by the muscle weakness and the steroids use. Hip, as you can see in the upper image, is the most sensitive site for osteoporosis, and the bone density starts to decline first, while spine and total body bone density stay stable for a longer period. And that's the reason why we recommend bone density exam every year for boys with Duchenne. And for spine X-ray, we recommend doing spine X-ray every year or two for boys who are using steroids, and every 2 to 3 years before starting steroids. And monitoring those two modalities, when we see the first signs of osteoporosis, which is a vertebral fractures or long bone fracture, we start using bone protection therapy. And this is the minimum standard of care for boys with Duchenne to decrease subsequent fractures and increase bone density. Our treatment of choice is intravenous bisphosphonates. Intravenous bisphosphonates are currently the most potent used agents to protect bones. The two most used agents are zoledronic acid and pamidronate, which have equal efficacy in protecting bone, but they do differ in some minor things, such as zoledronic acid is given over 1 hour every 6 months, while pamidronate is given over 4 hours every 4 months, but it is gentler in terms of side effects. In our clinic, we do use zoledronic acid because it is more convenient. How do bisphosphonates work in protecting bones? Bisphosphonate target the osteoclasts, which are the cells that normally chew bones, as opposed to the osteoblasts that build bone. In osteoporosis, osteoclasts are overly active, and that's why giving bisphosphonate can stun those cells, and they lose their ruffle borders, and they go to sleep and stop chewing bone. This is how we increase the bone density and decrease the fractures. With these medications, we might have side effects. Those side effects are usually more prominent with the first infusion of bisphosphonate and succeed with subsequent infusion. We do have a plan for tackling those side effects, as Tylenol, Advil for the fever and the bone and muscle pain, anti-nausea medication, and calcium supplement after the infusion. And for some cases, we need to stress those because we do see signs of adrenal insufficiency. And what's more important is to have your endocrinologist contact number or any medical provider to call if you have any concerns after taking the infusion. And it's important to know that with boys with Duchenne, some might still experience side effects with subsequent doses for a reason that isn't clear yet. And what is our goal for starting this bone protection therapy? Our goal is to have fewer long bone fractures, to have fewer spine fractures that will help us preserve the spine length and help us avoid deformity, and most importantly, to lower the risk of fat embolism syndrome. What is fat embolism syndrome? It's a very rare complication of a bone fracture or a bruise that can happen when someone is taking steroids or has suboptimal mobility. Because we do know that in these cases, fat cells accumulate in the bone marrow, which is within the bones, and in a case of a bruise or a fracture, those fat cells go to the bloodstream, form a globule, and can enter the lungs and cause shortness of breath. And that is the reason why we recommend that any child with Duchenne, in a case of a fracture or a fall, if he has shortness of breath within the 24 to 48 hours or neurological deterioration, he seeks medical help. So what's new in this field? We have talked about starting bone protection therapy with the first signs of osteoporosis. But can we prevent this first fracture? Can we start bisphosphonate before the first fracture? This is currently a discussion in the Optimized DMD consortium to find the best timing for starting bisphosphonate. Is it at the time of diagnosis or starting steroids or after 1 year of starting steroids? This is now the topic for discussion. And we do know that there are some pros and benefits for starting bisphosphonate therapy before the first fracture, what we call primary prevention. This could prevent back pain, further minimize spine fracture, long bone fractures, and possibly with this, we can prolong ambulation in boys with Duchenne. Unfortunately, for this strategy, there can be some cons, such as having more hospital visits at a younger age and having more IV pokes and IV intravenous medication at a younger age. That's why this topic is being studied. Hopefully, we will have answers for you with the next meeting. The other new development in the bone health is vamorolone. Vamorolone is a new distinctive type of steroid that has been approved in the United States since 2023 and currently is not approved in Canada, and for our knowledge is not under review by Health Canada. We do have knowledge of 3 years of research, and we do know that it has better outcome on bone health. Boys who are on vamorolone have fewer but not absent spine fractures, and vamorolone has better outcome on the bone turnover markers, which theoretically can improve the fracture healing and can help bone adapt to the mechanical loads of walking better than other steroids. Thank you for listening.
Great, thanks, Rana, for that overview. So that's part one. Now we get to open it up to your questions. These are the questions we've put forward to have you think about and discuss with us, but you don't have to stick to these. So first of all, are you aware of the notion of bone protection in Duchenne? Is that something that's part of your language and your care? Do you have a bone health physician or an endocrinologist to guide you in your bone health care? What are your questions about bone health care, given what you've heard today? And tell us about your experience with bone protection therapy. So I'm going to open it up now and encourage you to come forward with your thoughts and experiences. Anybody willing to kick off the morning? Yes. There is data on steroids 10 days on versus 10 days off compared to daily steroid. I should just repeat the question for the onliners. So the question is, do different steroid regimens give you different bone health outcomes? So what was studied as part of the 4DMD study was prednisone 10 days on versus 10 days off versus daily prednisone. And we know that daily steroid, daily prednisone is better for muscle than intermittent prednisone. And the flip side of that, though, is that the bone is protected with steroid less often. So the bottom line is you can give steroid less often than daily. It won't be as good for muscle, but it will protect the bones. So there's a balance there. I am, yes.
And we've recently been speaking with her, and she seems to believe that weekend regimens actually are at least as effective as daily regimens for muscle benefit. Yeah. Would you disagree with that?
Well, we would love to see her data. So she's published out to 1 year of use of steroids, and we haven't seen data beyond 1 year to know what the long-term effect of that intermittent approach is on muscle and bone. So very well aware of Dr. Connolly's work and would love to just see the data that supports that farther out. Anybody else have questions? Does anybody want to share their experience with bone protection therapy? How it's helped? Any issues? Hannah, do you look like you want to say something there? No?
Oh, yeah. Not waiting for the fracture to happen, because that's where we see some more dependence on our mobility aids and devices, which is fine. But if we can delay needing it all the time and just needing it there when we,
So Dr. Alazam is saying she's excited to hear us talk about starting bone protection before first fractures. And you may be saying, why didn't we do this long ago? And it's because we had to build the evidence to support what we were doing once you had a fracture. I think it's really important as we move through this field to always have evidence to justify what we're recommending to patients in the clinic. And so we now have evidence that when you start therapy at the time of a first fracture, you benefit patients. And now we're looking at starting before first fractures. And we're really interested to understand how the community feels about that. How do you feel about starting an individual with Duchenne who has not yet had a fracture? They may be 5, 6, 7 years of age. and putting them on an intravenous therapy. How does that sit with you? Is that something that you'd be comfortable with? Is that something that you would be concerned about? Because you're starting therapy before there's been a fracture and bringing the child into hospital more often than you would have if they were waiting for that first fracture and then triggering the osteoporosis management. Anybody want to comment on that?
Leanne, we do have something online, a
Great.
question. So with vamorolone showing better profile based on the data, but still not in standard of care, how are we proceeding forward to ensure we move forward towards having it a standard of care? Also, what options are available to have kids get access to this? Is there any difference in dose level, regular steroid versus vamorolone?
Yeah, so lots of questions about vamorolone, and we anticipated that, right? So as Dr. Halloun said, vamorolone is a steroid. It is what's called a dissociative steroid, where the goal is to maintain benefits to muscle, but without as many side effects. And so what we know about vamorolone, and Dr. Halloun's going to talk more about this, is that individuals on vamorolone grow better. They grow normally. So vamorolone does not negatively impact the growth plate. And it looks like the spine fractures are less frequent as well. We still see weight gain. If you were going to gain weight on your steroids, your classic steroids, you'll gain weight on vamorolone. We still see adrenal suppression. So in terms of moving vamorolone to standard of care, in Canada, it would need to be approved by Health Canada, and then there would need to be a way for that to be publicly reimbursed in order for it to move to a standard of care. And there would also need to be very clear guidelines for healthcare professionals and patients alike to know when it would be best to start vamorolone, because every individual has a different clinical profile, and one needs to consider the aspects of vamorolone that would make one want to go forward with that medication. For example, if height is very important to you and you're still growing, then that would be a reason to consider vamorolone. Any other? Yes, Lisa.
Dr. Ward, thank you. I'm just thinking about steroids in general and, you know, the age, often the age of diagnosis, et cetera. And you're talking about, you asked the question, how do people feel about starting sort of a regimen that would be protective prior to fracture? My question is just really around safety considerations. What is typically an age that we would be giving steroids to children and feeling like, yes, there's more benefit than not?
Mm-hmm. You know, that's probably a question best answered by the neuromuscular experts who actually prescribe the steroids. But I know that the data suggests when you start at a very young age, there may be issues with side effects over the long term, more fractures if you don't have bone protection, perhaps other side effects. But at the same time, you want to start your therapy as young as possible, right? So I think the standard of care in Canada is usually between 4 and 6 years of age, or around the time of diagnosis, or in the first 6 to 12 months after diagnosis. But there are conversations happening and studies going on about what happens if you start at a very young age. Any other questions? Yes. Bone protection.
When you talk about starting a protection therapy before the first event of a bone break, how would it work? Like, what kind of medical health panel would the child present to be able to do that?
Yeah, that's a great question. So what we're starting to think about, as Dr. Halloun showed you, you know, when the BMD goes down, like we see that, we see the bone density going down, which we know is a risk factor for fractures. So we're starting to think about triggering bone protection when we see that bone density go down, and it goes down first at the hip. But not every clinician looks at the hip. And so I do encourage people to look at the hip starting around 4 or 5 years of age. So when there start to be important declines in bone density, that would be the time to consider initiating bone protection therapy. And this is a new concept, know that. So not all clinics are doing this. And it's also an important discussion with the family. So the family may say, well, I'm not ready to start my child with Duchenne on bone protection therapy at 5 years of age or 6 years of age. Normally, when we follow the spine and wait to see the first signs of fractures, it's a couple, 3-4 years after starting steroids. So if you're following the spine closely, you'll already be starting at a reasonable age. And now we're talking about starting it early. And we're very interested to understand what families think about that.
That is a treatment that will be available for CHEO patients.
Yes.
Okay.
So we've started to talk to families about this. And I can tell you that families are embracing this notion, right? It sort of makes sense to try to prevent something from happening in the first place, doesn't it? It's sort of obvious to do that. Just balancing it against having an IV poke at a very young age and more frequent hospital visits. And that's what we're sensitive to and why we're opening up the conversation. And of course, any decisions we make would always be shared decisions, right? It's ultimately up to the family to decide when they would like to start bone protection, and we just provide them with the information to make that decision. Thank you for the question. I think we'll move on. We still have the other endocrine issues to move through. So Dr. Halloun will now pick up the conversation talking about growth.
Thank you, Dr. Ward. So this is a typical growth chart of a boy with Duchenne. Well, we can see that even before starting steroids, boys with Duchenne have a shorter stature than their peers for reasons that aren't fully understood. And when we start steroids, we can see that there is a deceleration in the linear growth and sometimes stunt in the growth. And what are the reasons for the short stature in boys with Duchenne? Growth hormone secretion is usually normal in boys with Duchenne. Growth hormone is the main driver for linear growth in children. It is secreted from the pituitary gland in the brain. It goes to the blood and from there to the growth plate, which is on the very end of the long bones, where it stimulates bone lengthening and linear growth. We do know that usually in children with Duchenne, the growth hormone secretion is normal. What happens is that steroids affect the growth plate itself. This is what we call end organ failure. So the growth hormone secretion is normal, and the steroids have toxic effect on the growth plate. This is why giving extra growth hormone to children with Duchenne have very marginal effect. Because growth hormone works better when there's a growth hormone deficiency. And when we are adding extra growth hormone to the growth plate, we see minimal results. It's also important to know that there are side effects for the subcutaneous treatment of growth hormone. There could be worsening of the scoliosis, there could be increased blood sugar, and increased secretion of the fluid that surrounds the brain, what we call pseudotumor cerebri, which can be manifested by headaches and sometimes impaired vision. That's why in our clinic, after weighing the benefits and the risk of growth hormone, we usually do not recommend this treatment, but this is a shared decision that we make with the families and the boys with Duchenne. And what do we know? What is new in the field of growth? What Dr. Ward has mentioned earlier, that we do know that vamorolone has a preferable effect on growth, and boys taking vamorolone continue to grow normally without the toxic effect of steroids on the growth plate. This is for our topic of growth. Thank you.
Thank you. So we'll open up the conversation about growth now. So what is your experience with growth in this condition? Is this an aspect of the condition that's concerning for you or for your child? And how important do you consider height overall in the overall situation? So opening it up to discuss height or growth. Great, thank you.
So Dr. Ward, we actually, as you know, have our son Julien, who's basically 12 going on 13. So hormone treatment is starting to become kind of the center of attention. He's seeing the difference between with his friends and things like that, though we do understand that it doesn't remediate the entirety of, what the condition that he has. we do understand that the pituitary gland basically does get stimulation and produce, or basically it supplements what's not there. I'm hearing today a bit something different, which is seems that it's the benefits are marginal. I'm interested more in that, right? Because we've been talking about it with our son, and for him, and I'll say like almost subjectively, he's grasping onto that, saying maybe this is a way for me to see life, have a chance at life a bit different, even though I'm in a wheelchair and such. So I'd like to hear a bit more about that, about the marginal effects versus not, and what are the cons itself, because we'll have to talk about to Julien about that.
So let's talk about that. Thanks for sharing that. For those online, we've just heard about Julien, who's 13 years of age, 12 going on 13, and is starting to think about his height and in relative to his peers. And he's got a really great friend set. I've seen some pictures of how active he is and engaged with his peers, which is wonderful. And he's sensing the differences there in terms of his stature. So here's the story. I'll just expand on what Dr. Halloun said so nicely about growth hormone. As Dr. Halloun said, the growth hormone secreted by the brain, the pituitary, is usually normal in this condition on steroids. The problem is the growth plate. So even when we give growth hormone, which acts on the growth plate, we can't override the negative effect of steroids on the growth plate. Years ago, like 15 years ago, even longer, I did recommend growth hormone in individuals with Duchenne because we didn't know a lot at that time and we wanted to help. And we do know how to give it safely as endocrinologists, so that was very much part of our wheelhouse to administer growth hormone. And none of the patients who went on growth hormone stayed on it longer than 12 months. It's a daily subcutaneous injection, or 6 times a week. You can have a day off. And they just didn't see, with all that effort, the benefit. So the growth is minimal, marginal, and it's because the growth plate doesn't respond. Yeah, just so now, we talked about shared decision-making, right? So everyone's different. Some people may want to try it. We would always give information to families and then work with them to discuss it. There are situations where the growth hormone itself doesn't seem to be working quite as well as it should be on steroids. So there may be rationale to try growth hormone in those situations. And so ultimately, it's a matter of shared decision-making, going on the therapy if that's something you want to do, and seeing how it works out. But in our experience and in the published literature, the benefits are marginal relative to the effort to receive that daily subcutaneous injection. So it's not standard of care. And there are international guidelines that have come out and said that this is not standard of care. It doesn't mean somebody couldn't try it, but because the benefits are marginal and there are side effects, it's never reached a level where we could say, yeah, this is standard of care. Yeah. So really appreciate the question there.
Yeah, just something to add on. This was a big discussion back when I was 13, 14 about growth hormone. And the one thing that we discussed was also going on testosterone and starting that, because that it can add a little bit of height, but depends what Julien is like more comfortable with, if he wants to be like as tall as his friends. And what the testosterone did for me was kind of like the behavioral aspect of it. And so that's a good discussion to have, like growth hormone versus testosterone and how that all works out. And yeah, I just thought that would be good to add.
Thanks so much for sharing that. We're going to talk about puberty next, so that's a beautiful segue. And I'm so glad you brought it up, because unlike growth hormone, as Eric just said, testosterone does work when you give it. It does work. The tissues in the body, even when you're on steroids, are sensitive to testosterone. So when we start testosterone for a boy with Duchenne muscular dystrophy, in order to deepen the voice and give some facial hair and virilize, that's the medical term for masculinizing, virilization, we do see changes. Now, they don't happen overnight, so you don't have to worry about your boy waking up suddenly the next day with a beard the day after he starts testosterone. But, that is something that does work. And as Eric said, you do get a little boost in height as well. Not a huge boost, because those growth plates are still stunned, right? And testosterone works on the growth plate normally, but the growth plates aren't functioning normally because of the steroids. but it works for the virilization, that's for sure. Yeah. So I'm so glad you mentioned that, and you talked about that last year too. Thanks for bringing it up, and it's a beautiful segue into puberty. So let's talk about puberty now.
Yeah, thank you for the introduction in the topic of puberty. Yeah. What is puberty? So we know that puberty is the time in a boy's life where there are some body changes like body odor, hair, and cognitive and emotional changes. And this is the transition from boyhood to adulthood. How does puberty starts? Well, puberty starts when the brain signals the body system, specifically the testicle, to start producing testosterone, which is the male's main virilizing hormone. And that is the reason why the first sign of puberty in boys is enlargement of the testicles and not body hair. When we see testicle size of 4 milliliter, that's our sign of true puberty. That's why if any boy with Duchenne goes to his or her endocrinologist, we use the chain of beads, what do we call orchimeter, to measure the size of testicles to know whether a boy with Duchenne have started puberty or not. The typical age for starting puberty in boys is 12 years. And when puberty is delayed beyond the age of 14, we call it delayed puberty. And this is the time when we can consider giving an external help to kickstart puberty. We do know that when we give steroids, they inhibit the brain's signal of initiating puberty and prevent testicles from producing and secreting testosterone. This is we know about deflazacort and prednisone, but this information is still under study for the vamorolone. And with delayed puberty, we know that there are some consequences for those boys. It's a lot of stress for boys with Duchenne. It can have functional impairment due to the small phallus, which can make it hard to use the urinals or a catheter. It can have psychosocial impact on the boy's life. And it can be a very difficult conversation to have with your physician. This is why it's important to have an endocrinologist beginning the diagnosis, to build a very good relationship, to have someone that you can have this conversation with. And that's why we start gauging a boy's interest in talking about puberty around the age of 12 years. And we do know that every boy's experience of puberty delay is different. Some boys are okay with the delayed puberty, while others want to start puberty at the age of 12 or the age of 14. And when there is no signs of puberty at the age of 14, we do discuss starting testosterone to kickstart puberty. And we do talk about the effects of testosterone on the physical change as well as the emotional. And as I said, if by the age of 14 we haven't seen any signs of puberty, we do recommend starting testosterone. Testosterone can be given in 3 methods: by intramuscular injections, by subcutaneous injections through the skin, which is given more frequently, or with cream or gel, which makes it a bit harder to adjust the dose with gel as opposed to the intramuscular and the subcutaneous. We do induce puberty in a very gradual way, starting with very small doses of testosterone to mimic true puberty. And after 2 to 3 years, many of the adolescents with Duchenne start true puberty, and we can stop those injections. And with testosterone therapy, as Dr. Ward said, we do see a growth spurt. It can affect the linear growth of a boy with Duchenne. We also see the virilization, which means more body hair, more enlargement of the penis, and changing in attitude toward intimacy and relationships. And of course, we have the unexpected and unwanted results, such as the acne and the body odor. And as for the side effects, they are very rare because we do use very small doses in a very gradual way. So we do rarely see side effects, but we do monitor blood work to follow those possible side effects. And beyond the physical changes, we do know that testosterone can have a positive effect on the muscle, improves muscle function as well as the bone, and can have very positive effect on the neurocognitive development in a boy becoming a man. And what's more importantly, that it has no negative effect on the cardiac muscle, which is very important for a boy with Duchenne. After starting steroids, we do continue to monitor the testicular size to see whether a child has started through puberty, and in this case, we can stop testosterone. We do monitor the bone age to see the skeletal maturation of the bones, which can help us anticipate the final height and adjust the dose. And as I said before, we continue to monitor blood work for possible but rare side effects. Thank you.
Great, so that's puberty. So we're wondering if you have a physician with whom you feel comfortable talking about puberty. That isn't an easy conversation, as Dr. Halloun said. That's one of the reasons we encourage you to have an endocrinologist early, so that you're not just for the first time at 14 years of age discussing puberty, that you've known this physician for many years before that conversation is brought up. When do you think it's appropriate to discuss puberty? We said that by 14, that's delayed. When would you like to have the conversation? Would you like it to start early versus late, or wait till 14? And when do you think it's appropriate to start testosterone in situations of delayed puberty? So I'll open this up to the floor and see what comments or questions or experiences you've had with puberty.
We have one online. My son had a testicle removed due to torsion. Would testosterone be affected?
Yeah, so the good news is you only need one testicle in order to go through puberty. I guess the second one is sort of a backup in a way. And so the removal of one testicle would not be anticipated to significantly affect the ability to go through puberty unless the individual is on steroids. Steroids are what shut down the ability of the body to produce testosterone. So I think in that situation where there's been a testicular torsion and the testicle had to be removed because of that, the conversation would just be the same as for anybody to talk about puberty and how the individual is feeling about their pubertal development or lack thereof, and together making a decision about when it might be necessary to start testosterone. Now, know this, I have patients who say to me, well into 17, 18, 19, Dr. Ward, I'm very comfortable not being in puberty. And we absolutely respect that, right? So it is the decision of the individual to tell us when they're ready, if they're ready to start puberty. Yes? Or do you want to go ahead? No, okay.
Sorry, I do have a question. It's still a learning curve, learning about male puberty. So we are talking about delaying puberty, but what is the effect if you see early puberty, like, for example, in a child 8 years old?
Mm-hmm.
How would that affect his growth, development, if it's early instead of delayed?
Yeah. So I personally, in 30 years of practice, have never seen early or precocious puberty in an individual with Duchenne muscular dystrophy. And the steroids delay the puberty. So without steroids, puberty is normal in Duchenne. So you would expect to see the earliest signs, which is the testicles getting larger around 12. And then the steroids are what delay the puberty. Now, that doesn't mean to say that an individual with Duchenne could not have a totally separate reason for an early puberty that has nothing to do with Duchenne. Sometimes that happens where someone has two different things going on. So certainly as an endocrinologist, we would be on the lookout for that. But that would be very unusual to have early puberty in Duchenne. And if you did, it would be for a completely different reason, unrelated to the Duchenne. Yeah, so early puberty is interesting. First of all, you have someone who's very young, masculinizing, and that's tricky. And we have ways of shutting down early puberty, fortunately. And then early puberty makes you race through your growth. Although if you're on steroids, that wouldn't happen. But if you weren't on steroids, you'd race through the growth and you end up being shorter at the end of the day. So early puberty causes this psychosocial situation where you're masculinizing at a very young age, and then you end up being shorter than you would have been if you had a normally timed puberty. So that's a great question. Yes, over here.
Yeah, what are your thoughts on the different steroid regimen and puberty onset?
Yeah, that's a great question. So, you know, in Canada, we use a lot of daily steroid, right? And it's been raised by one of our colleagues here that other places in the world use weekend only or twice weekly or 10 days on, 10 days off. The bottom line is this: the lower your steroid dose, even on daily, or the more intermittent your steroid, the less likely you are to have side effects. But from what we understand is the benefit to muscle may be different. And so it's a very personal conversation with your neuromuscular expert. What are your goals in terms of muscle strength? And what are your goals in terms of side effect management? And what we're talking about today is ways to minimize the side effects, even if you're choosing to be on daily steroids. And, you know, for families, the choice of steroid regimen is their choice, right? As physicians, our job is to provide information, and then everybody needs to go away and think about the benefits and the challenges of the different steroid regimens. So in somebody who's on a more intermittent regimen, they would have a greater chance of going through puberty normally without testosterone. In our clinic, we use testosterone intramuscularly monthly. I should say that's the choice the families make most often, but also the subcutaneous injection every 2 weeks works well, and more families are doing that. The gel and the sachets don't tend to be as popular. If mom starts getting a little testosterone from the gel or the sachet on her hand, she'll get a little furry. So we tend to, you know, we just tend to see families most often doing the monthly testosterone or the every 2 week subcutaneous injection. I see some nods there. So thanks for that question. Anybody else have questions or comments about puberty? Anybody with any experiences to share? I know it's a delicate conversation, and I appreciate that people are opening up about this. Yeah.
So Jacques Bertrand again, father of Julien, 12. Actually, with our son, we've actually had him, like it was him that was curious. So I think for the second point, I think it goes hand in hand. It kind of is a dance, right? Where basically you meet the child to where they are at, right? So if they feel comfortable, as you said, Dr. Wart, not being in puberty, you follow that along. If they're worried about it, I think it really warrants a conversation with your child and with the specialist. I really think that that's the great partnership that there is, and that's the experience we've had with CHEO. So yes, thank you.
Exactly. And, you know, as physicians, we're trained to sort of follow the patient's lead, right? So if I say to an individual with Duchenne at 12 years of age, how do you feel about talking about puberty, which is when you start to see those changes like, you know, hair on your face and body odor, and I see them pull their baseball cap down over their eyes, or they, you know, you can tell the eyes flicker, and you just know, right? But at the same time, we want the families to know, and the parents as well. This is the clinic. The endocrinology clinic is the clinic where this is going to be discussed. We're trained to have that sensitive discussion, trained to follow the patient's lead. And so this is what we hope for everyone, that you will be hooked up to an endocrinologist to allow that conversation to happen. Because what we don't want is for families never to know this is an option, that this is something that can be discussed. And we want the individuals to feel like they've got a forum to bring it forward. And sometimes the parents are hearing about this for the first time. If we say, how are you feeling about your puberty, your development? And then they say, well, you know, I would like to talk about that. And sometimes the parents go, oh, okay, we didn't know that. And this is good now to have that come out. Any other comments about puberty? Yes. You need a mic. Yep. You're getting your steps in today, Kate.
Sorry, it's more of a question actually. So the appropriate time to discuss, did I miss that, was 14 or when you're comfortable?
Yeah, so puberty is delayed at 14. So we would love in the clinics to have the conversation starting a little bit before that. And even before you start sort of maybe making eye contact with the boy and bringing it up, you can say to the family, look, one of the things we do in this clinic is we monitor puberty. And just letting them know this is part of what happens when you come to see an endocrinologist. And you can say that at any time. You can say that when they're 6, when they're 8, when they're 10. By about 12, we're gauging the interest in the individual and discussing that. In my experience, at 12, most individuals with Duchenne are not ready to talk about it. By 14, they're starting to open up. By 16, they're starting to be interested in therapy between 14 and 16. But we follow their lead. I have individuals who are 19 in my clinic who say, no, I am very comfortable with who I am and how I am, and I don't feel the need to change anything. So we just follow that lead.
So just for timing, Leanne,
Yes.
I know you have 2 more topics,
Yes.
correct? Do you want to go through them and then we'll have a little bit question after? So about
Sounds
10
good.
more
Both
minutes.
in one go. Okay.
Yeah, perfect. Thank you.
Okay, another delicate subject we're going to talk about, which is the weight gain. This is a typical growth chart of the weight gain in boys with Duchenne. We do know that weight gain can start before starting steroids, which is mainly because of the impaired mobility. And when starting steroids, the weight gain increases significantly. And we all know that once the weight is on, it's hard to get rid of. And that's why we try to start a plan and follow up for the weight as soon as we have the diagnosis. We do know that steroids drive weight gain through increasing appetite and the hunger, through affecting the brain centers for satiety and hunger. And as a result, we do see a very distinct type of weight gain that is called cushingoid faces, with round faces, central puddling, and overall weight gain, and sometimes with darkness behind the neck. And beyond the weight gain, we do see that there are metabolic consequences of this weight gain, which can be increased glucose, disruption of the lipid profile. And beyond these metabolic consequences, we do know that the increased weight can have effect on the body's emotional feelings, such as low self-esteem and even difficulties in transitioning from one place to other and even rolling in bed. And this is another topic that's hard to manage and to talk about with families and boys. And that's why we recommend early intervention from a nutritional specialist to accompany the family through the way before the weight gain, to have a healthy choices for meal, to eat together as a family, and to make healthy choices for the whole family and not just for the boy with Duchenne, and to limit screen time. And we do recognize that the weight gain is a very distinct and unique problem for boys with Duchenne, because there is the unwanted, uncontrolled weight gain because of the uncontrolled hunger, and there is less options for mobility. And that's why in our clinic, we are now putting a new protocol, a new strategy to tackle this weight gain issue through medication that can help improve the metabolic pathway of obesity. And maybe it can have a new opportunity for the weight gain in children with Duchenne. Okay. The last topic that we're going to discuss is the adrenal suppression that happens as a consequences of the steroid. We do know that when we take steroids, these steroids can suppress the body's ability producing steroids. In the body, it's called cortisol. Cortisol is the stress hormone. It is secreted by the adrenal gland after stimulation from the pituitary gland. This hormone is very important for maintaining our vital signs, such as the blood pressure, the heart rate, and the glucose. And as the name implies, the stress hormone, the secretion of cortisol increases in any stress situation, such as fever, vomiting, any accident or a fracture or a surgery. And the problem when we are taking external steroids is that the adrenal gland is dormant. It cannot secrete any more steroids, and it cannot increase the cortisol secretion when we are in a stress situation. That's why boys with Duchenne need to stress dose when they are in a stress situation. When do we stress dose? In any circumstances of vomiting illness, fever, if you have a flu symptoms that with them you are bedridden, or there's a surgery or a fracture, you need to stress dose. We use prednisone or deflazacort for stress dosing. This can be taken 2 to 3 times a day. What's important to know is that you cannot stress dose with vamorolone. Vamorolone too have adrenal suppression effect, but its half-life, time of action is shorter, and it is also suppresses the body's hormone that's responsible for salt retention. That's why if any boy with Duchenne is taking vamorolone, he needs to have an action plan with hydrocortisone for stress dosing. And the two options for stress dosing are the tablets that you can use if you can swallow and there's no excessive vomiting, but it's important to have the injection of the hydrocortisone to have when you have excessive vomiting or an illness that can prevent you from taking the tablets. And those are our ways of stress dosing. So it's always important to know that if you aren't stress dosing properly, you can have signs of adrenal insufficiency, which can be very non-specific and hard to recognize, such as fatigue, nausea, vomiting, headache, which can accompany any disease, body aches, and low blood pressure. It's very important to recognize the signs of adrenal insufficiency and to stress dose appropriately if you suspect any of these signs, with the tablets or with the injection. And it's important to have a therapy plan and an endocrinologist or a health provider that you can call and contact if you have any concerns. And the most important thing is that you can never stop steroids suddenly, because this will result in adrenal crisis in the body. And just to summarize what we know about vamorolone, as we discussed, you cannot stress dose with vamorolone, and you need to have an action plan with other type of steroids, such as hydrocortisone. We do know that vamorolone cannot prevent the weight gain in all patients. And we do know that there are some benefits of the vamorolone, as we discussed, with maintaining normal linear growth, and can have positive effect on lower vertebral fractures and positive effect on the bone turnover markers. What we have still need to study and know more in the vamorolone is whether it has a preferable outcome in the puberty progression, and whether it has the same effect on the muscle function and on the cardiac and the respiratory system, the same as the other steroids that we know. Thank you for listening.
Great, and I'll just supplement what you said so elegantly there, Dr. Halloun, and say with vamorolone, we have data out to 3 years, and we know that it has similar efficacy or similar ability to protect muscle out to 3 years, and it's beyond that we're starting to do research to understand what vamorolone and muscle health looks like over the longer term. So I hope we've convinced you that an endocrinologist in your camp is a good thing. I know we're tight for time. Any questions about weight management or discussion points or adrenal insufficiency?
I have one online.
Okay.
At what age should you begin seeing a dietitian after starting steroids to regulate weight?
Yeah, we think you should see a dietitian when you start steroids. As Dr. Halloun pointed out so nicely, the weight gain is early. And we all know how hard it is to keep the weight in check once you've gained, right? It's easier to prevent the weight gain than to try to recall it once it's on. So we know that families need to be engaging with a dietitian early when you start your steroids, to start talking about the implications of being on steroids and having that hunger, which is really different than in the non-steroid situation, and how to use nutrition as a way to try to keep the weight at bay. We also know that even with really good nutrition, it's still very difficult to prevent the weight gain. And we really feel for families in this sort of domain of weight management on steroid therapy. Anybody want to talk about their experiences with weight management, maybe successes you've had or challenges, or just how you feel about it overall? And what about adrenal insufficiency? I think in some ways with the most important endocrine vignette, you know, every year, unfortunately, I hear about someone who's had an adrenal crisis in Duchenne and they did not have steroid stress dosing. And that's really unfortunate. So we need everybody on steroids to have a steroid stress dosing management plan. If you do not, contact me and I will help put you in touch with somebody who can take care of that for you. And it is something that is ultimately not too difficult to grasp, right? I'm seeing thumbs up over there, and we've got tools to help you learn what you need to do. And you need to have your steroid stress dosing management plan when you travel, and when you're just local as well. And it can keep individuals with Duchenne out of hospital and help them get over their physical stress, whether it's a cold or a vomiting illness. So if you forget everything else we've talked about, remember that if you're on steroids, you need a steroid stress dosing management plan. Kate, is that a wrap?
That's a wrap. Thank you so
Okay,
much.
great. Thanks everybody for being such a great audience.